أنا اللي هنام بقى خلاص. بابا.
إن شاء الله يعني.
Okay.
Professor Omina El-Rashidy.
First of all, I want to thank all the attendees because they are all staying till now and you are so tired. So thank you so much for that. And I think I will pass in my slides much easier because the introduction with Dr. Noha Sarwat, Dr. Amara, Dr. Hoda, and Dr. Dina, it's not always easily to do. Genetic testing to inform global developmental delay management. My agenda include global developmental delay, genetic testing in global developmental delay interpretation, management of global developmental delay, and summary. I know it's all genetics, but it's not always genetics. For the junior staff, we are not doing magic. I will tell you how to interpret a whole exome sequencing. We don't know all these syndromes. No one of us know it. We just all copy and paste on Googling, and we Googling. Each of us Google his disease and take much time, and he's reading every part of the interpretation, even if it comes negative in the front. There is other variants inside. You must read it well, because in this reading you can pick variant of unknown significant that denotes your patient. So we are not magician. No one can know all that. You must remember that we all don't know that. It's by Googling. You never know that, but you must know when to ask for genetics. Global developmental delay is a frequent referral evaluation by pediatrician, neurologists, and geneticists. It's around 3 to 5% children that meet the criteria for global developmental delay. I think it's much more in Egypt because of consanguinity. It is defined as delay of 2 standard deviation below the mean in 2 or more of the mean milestones of our child. The main include motor, which include both gross and fine movement, language and speech, cognition, and personal and social adaptive behavior, or the quality in children below 5 years. Below 5 years, not after. It may be syndromic or may be non-syndromic. It may be genetic or may be acquired. You mean the acquired as external factors? Yes, the CP may be considered by subdivision. Some may consider the cerebral palsy for a maternal cause as a part of global developmental delay if he has another aspect. But usually we use this more for linguistic and cognitive and social behavior. My talk will concentrate about genetic, non-syndromic global developmental delay. This paper is 2023 about the evaluation of children with non-syndromic global developmental delay and intellectual disability. What is the algorithm? The child has nothing in the examination, nothing in the history. How I go in my investigation. Okay, detailed history is very, very important to exclude acquired cause. As Dr. Tariq Omar, you don't diagnose your case as hypoxic ischemic insult, except if you find the typical MRI of it, periventricular leukomalacia, or typical history and typical MRI. Otherwise, please don't more and more diagnose patient with CP because of hypoxic ischemia. If there is a genetic history of any etiology, you must go through your clue. You must find a clue. If you find a clue, never ignore it. You must go through. Abnormal head circumference or any focal neurological signs, whether microcephaly, macrocephaly, focal lesions, focal convulsion, you must go to neuroimaging. So MRI is mandatory in any case of global developmental delay? No, except if you have these 2 conditions. Okay, if you had epilepsy, of course. If no prior newborn screening, and this is the great debate, what's happening for the approach for global developmental delay. The inborn, the neonatal screening differ from each country to country. So we a lot because we take the guidelines for another countries have a wider and wider newborn screening. So we miss cases because we don't do this in our newborn screening. So take care. What are the newborn screening in your country? So not to miss cases. Most our cases diagnosed as inborn error of metabolism in amino acids or acyl carnitine profile or organic acids are already in the newborn screening of the developed countries. So take care of that, which country you are from. So don't miss inborn error of metabolism as a cause of global developmental delay in your patient, please. If any red flags of inborn error of metabolism as vomiting, lethargy, failure to rise, convulsion, and you know you have no newborn screening, you must refer to metabolic profile or for genetics. Do not to forget to any case hearing and visual evaluation. We don't do again hearing tests for newborn in some areas of the country and not other areas. Just the child may be decreased cognition because he's not speaking and delaying language because he's not hearing. And again, if you do autoacoustic to the newborn at birth, it is not accurate. If it's normal and you are still have global delay, you have to do auditory brainstem evoked potential after 6 months, please. Then you start your first tier of genetic testing after you finish the inborn error of metabolism. What I can do already, the karyotype is placed before that, before the first time. So it's not written. They do the microarray. Microarray, as Dr. Hoda said, is very expensive to us. And I shall let you see how much chromosomal microarray can detect causes of global developmental delay. So we are missing a lot, but we have nothing to do except to jump to another one. So if we have a male child with moderate or severe global developmental delay, please go to Fragile X. Testing is available in Egypt, in our national center, and in El-Qasr Al-Aini, Abu Rish. It's present in both. Any male with moderate to severe global developmental delay, he must do Fragile X. Again, I add something, which is the MECP2, which is the Rett syndrome. It was present in the previous guidelines, but I don't know why it is not present in 2023. It's any female presenting with global developmental delay, plus or minus microcephaly. You must again check for Rett syndrome, and again it is done in our National Research Center. So you have to do your karyotype, you have to do the inborn error of metabolism, you have to do routine investigation, you have to do karyotype, Fragile X if needed, you have to do Rett if needed, then you go after that to the whole exome and you're not jumping. So take care of that, take care what you are in Egypt, okay? If anytime we have microarray, I shall do microarray if it is free before I go to exome sequencing. Again, why in Egypt we go to whole exome and not panels? Because panels again are expensive and we may miss any disease. That's why we go to whole exome, because the patient is paying. So it is difficult to us, even with the insurance, to do both. So we are not going in the normal algorithm or the guidelines because of our country condition. So you must take care of that. So we go to whole exome sequencing, and it is better to be done, and I prefer to be done better than anything if you are going to pay money. And don't do microarray. Usually even the deletion of small microarray is appear in the all my patients appear in the whole exome. It was easy, but the karyotype, the big part, you must do karyotype. And can microarray replace karyotype? No. It's you can do karyotype and microarray, both of them. So okay, you can do it. Okay, if you don't do it, so go to whole exome sequencing. The line I have put is negative exome sequencing. Either you do whole genome, and you have another thing in the guideline. Do the whole exome every 1 to 3 years. I was about to fall down when I hear this. We don't have money for all that. Why? Why? Because what you are saying, you can do whole exome in one country and one lab, and it is another result from in another lab or another country. So it's not the same. It's not hemoglobin level. It's not an enzyme. It differ according what? According the data already present in each lab. He has already how much genes in his test, how many mutation he detecting, and the other is detecting more. It is a dilemma. It's something new for us who must take care of it. Okay. For me in Egypt, if I feel it is a dilemma and I will not gain much even from the whole exome, I go to whole genome because we are paying. But it is more economic. Even Dr. Lim is with us in UK. They start with targeted gene and panels because economically it is less for the country. But we have a certain condition in Egypt, you want to take care of it. So you must consider whole exome. Guideline for genetic evaluation, as I said, they were developed prior to the clinical availability of next generation sequencing, the guideline or investigation global developmental delay. So there is no direct guidelines you can pass through. It differs from one country to one country. But I recommend, as I say, chromosomal microarray if it is free and Fragile X and Rett syndrome. There are wide inconsistency with recommendation related to biochemical screening for inherited metabolic disorder associated with GDD. This is because the neonatal screening is not the same in all countries. So inborn error investigation differ from one country to another country, and there is inconsistency in the guidelines. Genetic testing, karyotype, chromosomal microarray may detect up to 15 to 20% of the cases. FISH technique is not used in Egypt now. Fragile X, as I said, Rett syndrome, as I said, and sequencing. This is the yield of each test. Global developmental delay gene panel, 20-25, whole exome 20 to 35, whole genome sequencing is 50 to 70, and this in this paper 2023. And this is the mean for all lab, not a certain lab. What to do? How to counsel about the result and interpretation? How to manage the patient? What's the implication of this result to the patient and his family? Management. The way to get started, to quit, talk, and begin doing. What I'm going to do for my patient? What are the benefits of genetic testing if it's negative? Relief. Relief of the family, relief of the patient, no genetic. It's not no, it's maybe, but mostly there is no genetic. So you can get another baby safely, but it's best it's to do the trio test, mother, father, and the baby. This is the best to get a negative test for me. Variant of unknown significance. This is a dilemma. I may have a patient with 8 variants of unknown significance. I start copy, paste, and Googling for 6 hours. Then I got a clue to my patient in my clinical. And I go through this clue to the variant of unknown significance, and I know what is the full picture of the disease and start investigating the other system and completing the investigation of my patient to reach an diagnosis. And I have a patient like that with 8 variants of unknown significance and produce, and in the end, it will, I think we begin treating his, because his MRI was vasculitis as familial microangiopathy. He were 2 brother and sister with variant of unknown significance, and now they are treated with the immunology department. But already, if I look to his West only, it is 8 variant of unknown significance. So clinical, complete your investigation. We must have multidisciplinary team if you have another subspecialty involved in your diagnosis. Positive to that, I have to manage. Refer well, define the urgency, coordinate, and achieve the team. Team and team and team and team. Okay, if it is treatable, like biotinidase deficiency, GLUT1 deficiency, Pompe, MPS, it's very easy. It's just for GLUT1, just like Dina, it's modified Atkins diet as she was. Dina is taking photo. Dina, please stop valprate your patient. It increase the disease, and give your patient Sidamax to improve his abnormal movement. Pompe disease, as we said, and MPS, and some type of thyroid lipofuscinosis. If I don't know what we can do, I found an app which I can put on it the mutation to find the disease and to find where is the treatment. Already I have the app on my phone. Anyone want to get the app? I didn't try it yet, but I just get it in the morning on my app. You find where is the treatment, is it is a research, is it is approved, which countries and which center. So it's very easy. You can reach if it's treatable or not. You have to say this to your patient, whatever your patient, poor or high class, all you must provide them with the knowledge. You must counsel. Okay, if no treatment, it is supportive treatment. Enables the minimization of impairment and possible complication and the maximization of activity, participation, health, and well-being of patient and their family. A family center, multidisciplinary, as I said before, to treat the comorbidities with epilepsy, behavioral challenge, sleep disturbance, movement disorder, and orthopedic. If it is one of the bed of catastrophic epilepsy, as we said, you can support your patient as you can. Please don't let your patient 3 or 4 months at hospital. It will never end. Okay, this one of the boy of 1.5 years old with mild global developmental delay. He has was his sister. They were consanguineous parents. The sister, the mother told me she has CP, and she knows CP, it was difficult labor, and she's a CP, epilepsy, not controlled, and she's different from my boy completely. Why is different? Because she started convulsing at the age of 4 months. She never gained any motor acquisition. Okay, what's about the other child, Muhammad? No, he can stand, but he's 1.5. He never walks, but I feel he's not understanding well. I was lucky enough that this patient was with my colleague, Dr. Mahasad. And she get the whole exam to me. The patient proved to be cerebral folate deficiency, a treatable disease. So the patient started cerebral folinic acid. This is the other one, we see it, I'm sorry. Okay, I have to stop. You have to stop it before to go to another slide, Dina. This is the child. This is the one at the back with the dark blue. He's coming, he's getting the ball. The child was normal. He is on folinic acid therapy for life. Normal cognition, normal motor, and mental. The other side is a female patient presented to me at the age of 6 months. She's consanguineous parents, 2 normal SIBs, normal neurodevelopment till 4 months. When she received the DPT vaccination, suddenly she got lost all her milestones, central hypotonia. Okay, what I can do? This is related to vaccination, of course. It may be a demyelinating disease or inborn error which become decompensated. Her MRI was normal, her metabolic profile was normal. Patient was not improving. She developed epilepsy. Okay, what I can do? Her MRI is normal, always normal. I go to whole exome sequencing. The whole exome come after 2 months. She was diagnosed as Krabbe disease. The MRI was normal at the start because they rush rapidly to me after 15 days. Her MRI was still normal. So it takes time. This is the girl in severe agony, crying, screaming. I was discussing that with Dr. Hoda. I have never followed up this patient till the end, and we don't have this experience. So we must go through this experience well to know how to support our patient. Bad news, counseling, how to counsel for bad news. It's we take a lecture. We never know in Egypt how to counsel bad news, how to counsel for near death. This child was private. Every 2 or 3 months, she's going private hospital, paying more than 30 or 40,000. She developed hypoventilation. What I can do every now and then, I can go to hospital? No, don't go to hospital, please. Just pulse oximetry. Get an oxygen beside her if she's need. Please, I'm trying to control epilepsy. I do a gastrostomy tube for her to continue feeding. I give melatonin, and now she's 16 months. They know that she will die by 2 years of age. Nothing to be done. Support the patient. Don't let him to die in hospital from sepsis. Don't let cases of refractory genetic epilepsy diagnosed to be fatal to die in our hospital. Please don't let them to go to the PQ. And at the end, not so bad news, but my summary, that genetic testing is essential and key in individual in whom the etiology is not readily apparent. In the era of genomic first approach, the underlying genetic causes of non-syndromic global developmental delay or intellectual disability, they can interchange these two expressions, could be explored with a variety of diagnostic assessment and result in high etiological yields. Every now and then we have new treatment, targeted treatment, and gene therapy. So advances is limitless in this area. You must investigate your child. This is the last app I have. It's called Phase 2 Gene app. The app can diagnose rare disease from a child from his face. Just I got it down. I will try both apps this week, inshallah. And thank you, and be optimistic.
Hello. Thank you very much, Dr. Omnia, for this very nice presentation. This presentation highlighted that clinical is the most important thing. We should have the clinical sense, and the most important thing even after the genetic test. So thank you, Dr. Omnia. Now we will end the session and the conference. Is there any question?
انا بس هسالك يا دكتوره امنيه بالنسبه للحاله الاخرانيه للكرابيه ليه يعني ايه الاسوشيشن ما بينها وما بين الدي بي تي؟
No association. You must know that that neurodegenerative disease may present acutely or gradually. So I have more patients have slowly progressive disease. So how to fit the life for slowly progressive? She will live 30 years with her family. How to do what you are going to tell the patient to do and not to do for this patient. I have one with a certain type of intellectual disability. I look for the survival and it was 30. What I can do for them and what I can do for the one who is going to die 2 years and what I can do for the treatable. We must have different plans to fit each child. But you can diagnose cases of neurodegenerative presenting acutely. I have another one with Duchenne presented with secondary inability to walk. Thank you.
Thank you very much. أنا بس في نقطة واحدة بس بحب أقولها، إن يعني الحالات كلها اللي بتتعرض ان بيطلع الوس يعني اللي احنا بنعرضه دايما اللي هو الوس البوزيتيف، لكن في حالات لازم نقول ان في حالات جلوبال ديفلوبمنتال ديلي بيطلع الوس بتاعتها نيجاتيف. فده وي ماست اكسبكت، يعني ان مش كل الحالات عشان ما يبقاش ابسط الواحد بعد ما بعت الوس لما يجي له نتيجه منها نيجاتيف، لان ده اكسبكتد. ان
انا قلت ان هو اخره 60% ده ماكسيمم،
يعني
واخر حاجه في الجينوم 85 ومغوصيته من العلم الا قليلا 15% في علم الله،
علشان الواحد بس ما يبقاش بالظبط كده بالظبط.
ولن يكون اخر العلم.
the West came negative, but there are many new genes.
Whole
still
genome,
identified.
I
And
have
and after that we could reach to the gene.
anyone.
After reading more the raw data and could reach the gene.
I have one case with Dr. Maha. She was have 3 childs affected. You phone me for this child to find to her a drug. I didn't find. The 3 died, but I got the mother and father do IVF pre-implantation diagnosis. They have a normal child.
Very important. Thank you very much.